Pass that mannequin exam. So you should know these basic things to do that. If you're going to be exposing patients, you have to have a certain knowledge of what you're doing. And if you're not able to pass this very simple exam, then I don't think that you should be exposing anyone to anything. Okay, so let's get started here today. Last semester, you learned quite a bit about radiography. So you should know a few descriptive terms for radiography. We talked about these things before: detail, density, and contrast. Detail is the ability of the radiograph to report sharp outlines of an object. So that allows us to see something with great detail and really make out the difference between one area and the next. So if you look at this image here, you can see an image that has less detail and one that has more detail. Of course, this is film-based radiography, but the same thing still holds, the standard still holds for digital as well. Here's another image, and you can see the pan, and then you see a pan, and the pan has much less detail than the parietal. So understand when we're taking images of individual teeth, of course, and we need to look at something in great detail. Parietal image is going to give us a better image. Next term we need to know about, of course, is density. What is density? It refers to overall darkness or lightness of the processed radiograph or digital image. Here we have an example of some different densities. Of course, something that's like on the left side of that, well, I guess the right side of the screen, very, very dark, very difficult to see. And then also you want to understand that when we deal with digital, of course, we refer this to a gray value. So the grays, of course, are the levels of grays that we're measuring in pixels. And we use the discrete, let's say the discrete numbering system for pixelation. So we see that extremely gray, dark gray value there on the right. That's not what we want. We want something more in the middle that we can really examine with our eye. The other thing is that the computer will allow us to kind of refocus that image and either adjust the contrast to make it a little lighter or a little darker. So we can get a better view sometimes of what we're actually trying to see. So contrast refers to the differences in density, the shades of gray. When a film is exposed to different amounts of radiation, we'll get different shades of gray. So a high contrast gives few shades of gray, and low contrast gives many shades of gray. And here's a couple of images, one at 50 kVp, one at 100 kVp. You can see a high contrast image with that 50 kVp and a low contrast image with 100 kVp. What does kVp mean? Kilovolts potential, right? What are our machines set at in our clinic? Well, I heard 70. That's correct. I didn't hear it confidently, but I heard 70, and that's what the machines here are set. Generally, the machines in most offices are anywhere from 65 to 70. There are some 90 kVp machines out there. You probably won't encounter those if I should go okay, contrast. Contrast depends on a couple of things. Number one is the thickness and density of the tissue. Number 2 is the kilovoltage setting of the X-ray unit. And a lot of these newer machines, like we have downstairs, it's already preset. Like older machines, I have an old machine in my office that my dad had when he opened his first office in 1971. I still use that machine today. It takes great images. It's been tested and rewired, all sorts of things, you know. But the amount of radiation we're exposing to the patients are pretty low now because of the digital imaging. It's not requiring as much. In fact, so much so that they are, a lot of the states are doing away with the lead apron in some instances. So that's a good thing. Low KVP, high subject contrast, may be better for detection of carriers. So we look back here at a low KVP, the low KVP image, and you can see the high KVP gives a lower it has a lower contrast, and we're able to see the shades of gray better. You're able to examine that image a little better than you are the high contrast image. Processing, well, processing now is by the computer, so we don't have the film to deal with as much unless you happen to be in a situation that some of the some communities or some organizations still have film-based, and there are some providers that prefer it. Supposedly the line pairs, I think I told you all of this in the fall, that the line pairs are greater in film than they are generally with digital sensors. So, but the technology is changing, so it's probably 50-50 today, but I would say in the recent past, film has still been labeled as a better image producer than computer-generated digital images. So processing film and storage of film is a big issue. The images don't last that long. You know, you go back to look at your records in 7 to 10 years, you may not actually see the image maybe after a few years. And that depends on how they were exposed when they were to the chemicals, how they were developed. So all of those things play a factor in how long the image lasts. But with digital, of course, the image, it doesn't degrade. So what constitutes a good dental radiograph? What do you think we need to see? So we want the image that's sharp. The image is clear and distinct and in focus. We want to see the object at the same size. We don't want to see any distortion. We want the image to have no magnification. We don't want it to look larger or smaller. We want to see the maxillary, like when you're looking at a root of the tooth, especially the maxillary or the molars, we want the molar roots to look approximate and equal and level if possible. That'll give you an idea of where they actually are. So when you're actually doing a root canal or you're doing or you need to evaluate in this particular image, you evaluate the difference between where those roots are in relationship to the sinus. You can actually have some confidence about what is going on. If this image is tilted or angulation is changed, then you lose that confidence factor. You don't want the cusp tips to be superimposed if possible. The anatomic structure is not superimposed upon the apices of teeth. That's another thing. We want to kind of see that apices as clear as possible. We want 3 millimeters at the apex of the tooth. We want to make sure that what we're looking for is the center of as close to the center as possible. What's your question?
So you don't want the cusp tips?
Well, You do want them, I'm sorry, you do want them superimposed. If they're not, then they're gonna be somewhere else on the image. And usually that's a good indication of whether the image is level. So if I took the speaker and I turned it to the side, it's not gonna be superimposed, it's not level. If it's more like this, then it will be level. Sorry for that mistake. So again, repeat that one more time. We do want the cusp to be superimposed on one another. Okay. Rules of casting shadows. Why are we talking about casting shadows? So that's what we do when we take radiographs. So some of the rules, these are the 5 rules we want to focus on and we want to understand. Number 1 is we want the radiation source to be as small as possible. When the radiation source is small, that means we will get a finer, a sharper image. I'll show you a slide about that. The next thing is we want the source to object. So source being radiation source, and the object that we're trying to get an image of, we want that distance to be, and I'll say as long as practical. In other words, if your tube head, your collimator, your PID, the device that you kind of controlling the panoramic PA unit with, is 12 inches long. That's maybe in that range, 9 to 10 inches is a good distance. The ones in the lower level clinic, they're like 4 inches long, which is not ideal, but that's the way they're selling those units. But you want that distance to be as long as possible to give you a good, help you get a good sharp image. We'll go over that. And then we just understand these principles. We want our object to film distance as short as possible. So that's the tube to the image. And we're trying to capture T. So I'll speak of the object as a tube. We want that distance as short as possible. And we want our object and film parallel. And when we talk about the cusp tips, we want them to be, we don't want them, we want them superimposed on one another. So that'll give us some indication that the tooth is level and that we're getting a more parallel image. And then we want our source perpendicular to the object and film. So these are the kind of questions they like to ask you on the board. You should be able to label this diagram. You should know what the source is, and that's your X-ray tube. The object is the tube. The film is, or we'll call it film or sensor. The penumbra is a zone of unsharpness. Penumbra is a zone of sharpness. And one of the reasons we want our source a small spot, if you look back in your textbook, you'll see that when you have a small focal spot, you'll have a smaller amount of penumbra. And that gives us a sharper image. And here's the diagram, kind of going over those principles we talked about. So penumbra is the amount of unsharpness or fuzziness of the radiographic, the unsharp. And the umbra is the total area of the shadow. That's that black. Actually, it's not the black area. It's a black area. Anybody have any questions about that? So 2 fundamental intraoral radiographic techniques that we use is what we use downstairs. Paralleling is our major number 1 thing that we try to do, and we use those XCPs to get a parallel image. The second thing we use is another technique called bisecting the angle, and then we have a separate little device to actually hold a sensor. Sometimes you even have to have the patient participate to hold the device and hold it in place. There are times when there are fluoride in the mouth, things that don't allow you to use the XCP. You have to be able to still capture an image, and it may not be a perfect image. And sometimes you may have to take it 2, 3 times. You have to get, when you're taking these images, you have to get the best image that you can, so you can offer the best information and be able to come up with a diagnosis or aid in your diagnosis. Sometimes that can be really challenging, especially on kids and like I said, patients with very, very large fluoride in their mouth or even their mandibles. Sublingual fluoride are very difficult to work around. And XCPs just don't work. So snap arrays do. I think I have a picture of the snap array. We'll get to that in a second. So this is the diagram of how bisecting the angle principle works. Basically, have a little, it's basically like a triangle. The center of the triangle that produces those right angles. That center line would be the axis of your tooth, and then one side would be the film. So A to B would be, we'll just say A to B would be the source, and then A to C would be the center of the thing itself. And then you can see here's another version of it. Now you can see, maybe I can visualize the triangle. This would be one side of the triangle, A to C. This would be the, so I think I said that wrong. The axis of the tooth would be from the tip of the tooth. We'll call this area here would be the palate. This is the long axis. I said that incorrectly, so I'm going to make sure I get that right. I'd even like to rotate this slide around and make it a little easier to understand. So the A to C would be our sensor or film. The center line would be the tip of the tooth, which would be A to the palate, and then A to B our actual let's go to actually be our access of our, we'll call that our tooth or our sensor side. Everybody see that? So make sure you go over these 2 slides and understand that relationship. Remember, A is the tip of the tooth. Make sure you know A to C. This is the device that we use to take those images when we use the bisecting the angle technique. It's called, I would say, in like we call Xerox, we used to call making a copy, a Xerox copy, because they kind of developed the technology that made good things. Even though Xerox is the company, Snap Array is, I think, is the company that came up with this positioning device. It's really just a sensor or film. Okay, this is this is a typical bisecting the angle shot. What's one of the things we just talked about? The young man asked a question about it. The cuss tips, they don't look that flat, do they? That's kind of the thing you'll get with a taking a bisecting the angle type image. This image is acceptable. You can use it to diagnose most of the things. You may have some issues and some information you may need or not need. But now we can identify the problems. The roots are elongated, right? So we have an elongated lingual root. We have foreshortening of the buccal roots. Buccal roots look real short now. Possible. I mean, they could be that short, but because we have an indicator of those cuff tips looking the way they do, we know something may not be quite to scale. Alveolar crest is not below the CEJ. Boy, that's something we need to take a look at. Maybe on probe and check that to verify whether that's true or not. So there's some things you can identify, and of course you can see 3 millimeters above all agencies, so that's not a problem. But something we're gonna be aware of. Okay. So here's an image of a paralleling technique. And you can see that the film of the sensor is parallel to the central axis of the tooth. And we should get a nice, no foreshortening, no elongation. The tooth scale should look pretty good. So we should be able to see the tooth. It should be close to an actual size, and that's why we prefer to use the XCP sensor holders. It helps eliminate a lot of the errors that go on with taking these images. Okay. We're going to move along to our next lecture for the next 10 minutes so we can get ahead of schedule. Summer is a shortened session, so it's important that we're here at 8 a.m. on time. Our quizzes will begin at 8 a.m. So if you're not here for the quiz, that's going to be your tough break. Okay? Just a reminder. So what are we talking about when we're looking at images? One of the things we need to be experts in dental anatomy. So this next lecture is going to cover all of these anatomic landmarks. You should be able to identify these on PAs, on PANs, on CBCTs, on any imaging that you take in your office or here at the school. You should be able to identify all of those things on that list. So here's an image. Teeth are composed of pulp, enamel, dentin, cementum, which is usually not visible. Right? So what can we see here? We see enamel, we see dentin, we see pulp. Right, some basic things we need to see. Of course, here's this film, and the image quality is a little fuzzy. Yes, not that sharp on the screen. It looks a little sharper on the actual slide presentation. So that's just something to note. So cervical burnout. A lot of times, newer providers will want to call an area that looks dark at the area that looks dark at the CEJ. You can see the arrows. They indicate a little darkened area around the premolars. And they might want to call those cavities. But you can check. Of course, you should take your Explorer and go in and check to see if there's any decay there. Something to look at. So be sure to understand the concept of cervical burnout and what causes it. And you just overexposure. I think too much radiation comes through there and it looks darker in those thinner areas. Canals open at the apices of adult incisors. So sometimes you get these little areas that look darker around the roots of the teeth. It's around the apical foramen. just have to understand what they are. And you don't want to identify that as pathology when it's normal anatomy. So we have to know the normal so we can understand the abnormal. So although the root canal is not radiographically visible in most teeth, I mean, we assume it's there. Usually you can tell you have a nice healthy bulb in the tooth, and generally in all the teeth, and just because of the last 2 or 3 millimeters, you can't see it that well, it doesn't mean it's not present. Usually when you have a nice healthy bulb, you can assume in those situations. So I will never forget that I got this wrong on my residency at USC. Extract the tooth, and of course, what do we call that? That's the lamina dura. Or for some reason, I call it something else. So as kind of thing where you have those mistakes and you never forget them after you make them. Yeah.
No, I think they are meaning it's not.
Yeah.
I think that's what they're saying.
Well, I had said
Oh,
normal anatomy. You can't always see.
Yeah.
Yeah.
Yeah, no, you said it's just a label. It's not-
Yeah, the label.
Yeah.
Okay. Might have to write a letter to the book.
We forgot to so we think it's
Not to tell, I'll give you the information. Oh, yeah, these are whole slides. So make sure that you can identify what's normal. Of course, that radiolucent area around the tooth is what? PDL, yes. Double periodontal ligament space in lamina dura may be seen when there is a convexity of the proximal surface of the root. So sometimes you'll get an overlapping area there in these little areas, and it'll appear that way on the image. Sometimes you'll see a bubble root, and it'll have a mesial component, a bubble component and a lingual component. And the way they kind of overlap one another, you get this appearance that you have 2 PDLs, and you do. But it's actually a second root, a second portion of the root back here in this area. So that's why you see the 2 PDLs. So that you can be able to see one here as well. Again, we don't want to label that as pathology. Normal anatomy. Alveolar crest, see here as seen as cortical bone, and you can see the difference in density of the tissue. Here, and see what's more corticalized, that's or the lamina dura extending into this alveolar crest. Again, normal anatomy. Looking at my clock here.
8:31.
So PDL space is seen as a narrow radial lucidity between the tooth and the root of the lamina dura. I think you all can all see that. Now there are different trabecular patterns. They're different in the anterior maxilla, they're different in different portions of the mouth. A posterior trabecula look different than the anterior trabecula. So make note of that. And there is actually a question on the test, I'll tell you now, not the test, not the quizzes, but on the final. So make sure you know the differences between why these trabecula or that they, I'm not just understanding the fact that they do look different and what's different about them. It's a little more dense, it's a little larger. Anterior nasal, anterior maxillary suture. Here's a curving radiolucency in the midline of the maxilla. You can see here, we'll see the curve. You don't want to call that a canal. Make sure you understand the difference and what it looks like. So, again, frequency of looking at these images will help you to become more proficient at reading these images, and you gain more confidence, and all of a sudden these things that may appear abnormal when you first look at it, you find that they are normal. But you have to look, because it's going to look different on one patient to the next. So you have to spend some time, pull out, go on the internet, you can put in anterior. You can put in intermaxillary suture, and then on Gmail, on Google, and then you can hit images, and then all of these images will pop up of the same thing. You may be able to see 10 or 15 different ones. It's a great resource, a great way to really get used to reading this stuff. You have to spend time with this. This is not a one and done type of deal. You're going to be doing this the rest of your life. So become the expert that you profess yourself to be when you put up your shingle outside your office and ask for business. You should know that there are certain things that you have to be good at. So definitely identifying what's normal. And so you can make the proper referral. Something doesn't look quite right. Here's a image of the anterior nasal spine. You can see how we put more brightness or lightness to the image in that area. Different from what's down here, the suture. Now this looks different up here. This is where I had planned to stop. So as you can see, we covered about 10 of these today. So make sure you know these first 10 and look at them, because you probably will see them at 8 o'clock next Wednesday. Okay. So Dr. Steins and I had a conversation yesterday about what D2s can do. So you all are going to take this 1 minute. For some of you who got patients, have been assigned some patients, you're probably on a D3's patient roster right now. You have to actually assign any individual patient, but you'll be able to start doing hygiene on these patients. So get with your D3 partner. That's who you're supposed to be working with in the clinic, and you should be shadowing as much as possible so you can learn how to do the procedures. The assisting is a great benefit to you and gaining confidence in the clinic and actually doing the work you'll be doing hopefully the rest of your life. My dad is 80, I refer to my father a lot. He's 83, he's an oral surgeon, he's still practicing. He's at work till 6 o'clock last night. So, not because he needs to, just because he likes it. want to sit on the couch. Some of us want to do that, but not everybody. Okay.
If our D4 partners don't have any patients right now, then what are we about to do?
You can go check with Ms. Harris, Professor Harris, about hygiene, and you can work with area. But I am actively on the D3s. I'm gonna have a conversation with them today because just like you, when you get your patients assigned, you're gonna be assigned that you're gonna have to set up all the recalls for your patients. You have 20 patients on your roster. You should have about 40 cleanings to do on your patients over this year. That means 20 patients would each get 2 cleanings in a year's time. So you should have a little calendar, and you should kind of be penciling in what months of the year that you're going to be seeing these patients. And that's what they have not had to do in the past, what they will be doing. And I've told them that I would like them to see the patients if they can, but they're supposed to bring you all in and help with that. And that's what you should be doing this summer, doing a lot of hygiene and learning how to do your exams and take your images on the patients, those kind of things. So, and then assisting as much as possible. Shadow them. I mean, it's up to you to be with your partner. The D3 should be looking for you to come and help. You should make your schedule known and make yourself available as much as possible. And then they'll be tracking whether you're in the clinic or not. So that way, when things get tight for you and you have been doing what you're doing, it's easy to help somebody when you can see them and help them. Been out there working hard. But when you haven't been doing what you're supposed to do, when you don't come to class, when you don't do those things, then it's difficult. It becomes difficult for us to